Thank you so much, Bill. It's always a pleasure to come and talk. Before I start, before I say anything at all, I just would like to compliment the Mended Hearts group. You guys do so much for our patients, and I can always tell when I'm working on a patient that has met with one of the Mended Hearts volunteers. They come into the operating room with a completely different energy. They're informed, they are aware, they are much calmer, much more reassured because they understand what's happening. The patient's energy, I truly believe, impacts what happens in the operating room in a big way. My crew knows that, and I've handpicked the people that work in my operating room with me. When we have people that come in with all kinds of nervous energy, we'll take an extra 5 or 10 minutes just to calm them down, slow things down, make sure everybody understands what's happening. And if there's any questions, any uncertainties, those we like to be put to rest and the patient reassured before we get going. That is actually critically important. And I can't tell you what a wonderful job the group, Mended Hearts group, does. And you're not appreciated enough for it. So I just want to say thank you very much for doing what you do. My task today is to talk about replacing heart valves without opening the chest. This is a technology that we brought here almost 10 years ago now. We did our first case in April of 2015. So it's been a journey, and I'm going to share some of this journey with you. The procedure is called a transcatheter aortic valve replacement. And this is our heart team that does this. We've got valve clinic coordinators, Crystal Hastings, Julia, Tara DeGrazia. They run the program. They're the ones who get everything set up efficiently. They get the test scheduled, your appointments made, and they are just amazing women. They're what makes the machine work. And I want to say thank you to them. Our cardiac surgeons, Dr. Wilson, who's been here, I think, almost as long as I have, and then Dr. Logsdon, who joined us, I think, about 4 or 5 years ago. Terrific surgeons, really good at what they do, and very supportive of the program. And it's been fun working with them. Dr. Frutkin and I are the ones who started this program 10 years ago. And since then, we've recruited 2 younger cardiologists who have actually been through training programs to work on bad valves. Dr. Penglori and Dr. Sharma have both done 1 year of interventional cardiology fellowship in addition to their previous 7 years of postgraduate training, and then another year of structural heart fellowship. So they have finished a total of 9 years of postgraduate training to be where they are today. Both exceptional cardiologists, and we're very happy to have them as part of the group. So that's our team. I'm going to talk a little bit about the first patient we did. This was a 92-year-old gentleman. Okay, he was pretty active in his community. He had bad arthritis, was getting progressively worsening symptoms of shortness of breath, being able to do less and less, would run out of air. Liked to play golf, stopped playing golf, hadn't played golf for about 6 or 8 months. He got diagnosed with aortic stenosis. He was in the hospital. He was 92, active but frail. And he was our first patient that we did in April of 2015. At this point, the procedure was actually approved only for patients who were turned down by surgeons. It was not approved for everybody. It was considered early in the technology space, and the FDA had approved it for high risk or prohibitive risk patients who could not have open heart surgery. So at 92 years of age, there was no surgeon who was excited about trying to operate on a 92-year-old. Although the surgery would be successful, it's the recovery afterwards that becomes very, very difficult. You don't recover from a big operation like that at 92 as when you might at 60 or 65, pretty straightforwardly. So he actually had his valve done, was discharged from the hospital. He went home after a 2-night stay. He finished cardiac rehab and went back to playing golf, and then got so annoyed about his knee that was bothering him, he went and had a knee replacement, and went back to playing golf. And he was doing really well independently, and he passed away when he was 98 years old. 98 years old, not from a heart problem, mind you, but very functional. So we'll talk a little bit about what the aortic valve is, what the clinical course of a bad valve is, and how we go about doing valve replacements. Here's your heart. I have an arrow here. Yeah, okay. So this is a normal valve up top. Okay, if you're looking at it from above, it's about the size of a quarter, maybe a little smaller. It's got 3 flappers on it. This is what it looks like when it's closed. This is what it looks like when it's open. In aortic stenosis, your valve starts to look like this. It becomes hardened, calcified, and scarred. And when it doesn't open properly, the narrowing becomes smaller and smaller. As a result of this, and this is where the valve is situated, it's this valve. So when the heart pumps, the blood comes through this valve and goes to your head, to your body, to your limbs, to your other organs. This valve, as it becomes smaller and smaller, the heart has to work harder and harder to pump blood through, okay? And a normal cardiac output is anything from 3 to 5 liters of blood in a minute. So that's how much blood is getting pumped through this valve every minute, 24/7 for your entire life, right? Now think about how when this valve starts to get narrow, the heart's having to work overtime to try and push the blood through. And what begins to happen is the blood begins to back up in the lungs. The lungs get boggy with fluid. You can't get enough oxygen because the lung parenchyma, the tissues of the lungs, are waterlogged, so to speak. And you become more and more short of breath when you exert. The more you exert, the more back pressure happens in the lungs, right? So your exercise tolerance begins to deteriorate. That's on the back end. On the front end, what's happening now is there's not enough blood getting to the head. And if you exert too much, there's not enough blood getting to the head, you can pass out, you can lose consciousness, right? The other thing that happens is you have a lack of blood supply to the heart muscle itself, and that can cause chest pain. So those are the 3 main symptoms that we look for in patients who have aortic stenosis. And that's what we just talked about, right? Chest pain or angina, the shortness of breath, near syncope, which is passing out or actually passing out. And then abnormal heart rhythms can also be triggered by this valve problem. When you listen to the patient with a stethoscope, what you hear is a murmur. And I'm sure everybody's heard about a heart murmur. And the simplest way I can explain a heart murmur to you is if you have water coming out of a garden hose and you stuck your thumb on it, that water would come out faster, right? So as the valve narrows, it becomes more and more narrowed, the velocity of blood flow coming through that valve increases. It goes faster and faster. And when we put our stethoscopes over the valve, that's exactly what we're hearing. So those of us that do this for a living can actually listen to a heart murmur and tell you whether you have a valve that is mildly stenosed, moderately stenosed, or severely stenosed, right? Just from the loudness, the length of the murmur, those are things that we can distinguish. Now that's just the physical examination, but then you also have an echocardiogram, and that's what this is. This is an ultrasound of the heart, and this is what a normal valve looks like. It's the aortic valve. It's right here. And you see it opening and closing, two little flappers up there. The valve down here is the mitral valve. And in a patient who has aortic stenosis, this is what the valve looks like. See how it's thickened and it's hardened, and it's really not opening like it should. And this is a top-down view on the valve. You can see a little Mercedes sign when the valve closes. And when it opens, you just see the leaflets moving out of the way. The aortic stenosis valve looks like this. It's hardened, it's calcified, and it doesn't open properly. Okay. And these are the measurements we look at. So the valve velocity, which is what we just talked about, how the blood flow goes faster and faster. Once it's over 4 meters per second, that's qualifies as severe aortic stenosis. If we have a way of measuring what the pressure inside or above that valve is. If that pressure is over 40 millimeters, and if your valve area calculus to less than 1 square centimeter, those are all measurements that tell us that the patient has severe aortic stenosis. So what is the prognosis of this patient, right? So if you have aortic valve stenosis and you've begun to have symptoms of shortness of breath, dizziness, lightheadedness, passing out, chest pain, left untreated, 50% of these patients will not be alive 2 years later. Okay? And at 5 years, 80% of them will have passed away. So this disease actually has a worse prognosis than a lot of cancers. And up until now, or up until not so long ago, the only option was really open heart surgery, where you took the bad valve out and you sewed in a new valve. Right? We now have an option that is less invasive and allows us to treat older patients without the morbidity that goes along with a big operation. So here's the conventional way of doing surgery. You cut the sternum, which is the breastbone, open. You expose the heart. The patient is actually put on a machine called a heart-lung machine, which does the work of the heart and the lungs. So it's oxygenating the blood and it's pumping the blood through the patient's body. This, you pack the heart in ice, and you actually stop the heart by injecting potassium into it, right? So the heart's actually not pumping when you're doing a valve replacement with surgical techniques. You cut the aorta open, which is where the valve is. You cut the valve out. The bad valve is actually cut out. And you take different size cylinders and you put them in there and you go, oh, it's a 23, no, it's a 24. Okay, give me a 24 valve. Your staff opens a 24 valve. You put it in there. You put in 40 sutures to keep it in place. You suture back the aorta. You jumpstart the heart with paddles, and you slowly wean the patient off the heart-lung machine and let the heart begin to beat. All this is going on when the chest is open now, right? And then you close the chest with stainless steel wires because you've cut through the bone, and that bone has to now heal. Right? So it's a big operation. You're talking, in the best hands, it's an hour and a half, 2 hour operation. Sometimes it can take as much as 3 and 4 hours. And then you have the recovery from that operation. Now, the surgeons do a wonderful job, and it's amazing to think that someone can actually do that, bring a patient through an operation like that, and that patients continue to do well for many, many years. But it was a good option for a healthy patient, for a young patient. But as patients got older, we, as cardiologists, as the ones that looked after them, we realized that these patients were not recovering well. You know, the surgeons would look at our patients and they'd go, "Oh, you're all healed," and they were. They're all healed from the outside. And the patient goes, "I don't feel like I'm healed." You're not, because from healing from the inside can take 3 months, 6 months, and that is what we were seeing with our older patients. So this new technology was really a big breakthrough for the patients that were not great candidates for surgery. So here's a little graphic of the patients who did go surgical valve replacement, right? So if you didn't treat these patients and you just managed them with medications, then within 2 years, half of them had passed away. But if you did operate on them, even the older patients, you did operate on them, most of these patients did really well. You only lost about 20% of them out at 5 years, right? So although we had a option that involved a big operation, we knew we could significantly impact somebody's survival, right? So the issue then became with what we're doing now with valves, without opening the chest, are we able to do that? And in fact, we are, right? So, and the data has reflected that. So in the United States, there's about 250,000 patients every year who meet the indications for valve replacement. Historically, only about a third or less of those patients get the procedure done. They were getting the surgery done. Up to 2/3 of these who could have benefited from surgery were not undergoing surgery. Okay, why? Because of these reasons: older age, frailty. I mean, if a patient came in, they were 85, 86, even though they were fairly functional, most surgeons would be a little hesitant to go in and do such a big operation, right? Heart failure, a lot of patients who are now at this age have already had open heart surgery once. They had a previous valve replacement, or they had bypass surgery, which was very common 25 years ago for patients who have had open heart surgery for blocked arteries. The aorta could be heavily calcified, which becomes prohibitive for the surgeons, because what they have to do is they actually have to put a clamp on the aorta. If your aorta is very calcified, it can crack, right? And then you've got all kinds of trouble, because now you're talking about not only replacing the valve, but replacing the aorta as well. It makes a 2-hour surgery into a 3.5, 4-hour surgery. So all these things start to come into play. And then as patients get older, they're dealing with other illnesses that they may have had. They may have had a prior stroke, they may have kidney problems, they may have lung disease. All of that impacts their ability to have a big operation. So this is what was approved for TAVR, for transcatheter valve replacements. In 2011, prohibitive risk and high risk patients were approved for the TAVR procedure. So we basically we have a way of calculating what a patient's risk is of dying from an open surgical procedure. If their risk was over 8%, then the patient qualified to have a TAVR procedure. So as you can imagine, when we started this program, we were looking after the sickest patients, the ones that nobody wanted to operate on, the ones that nobody wanted to try and intervene on. And that in and of itself was a challenge, right? It is now, over the years, what has happened is the patients that were intermediate risk in 2016 were approved, right? And now even low risk is approved in 2019. So this technology is less invasive, and you're able to basically deliver a valve to a beating heart with this technology. There are different ways to approach the patients. Where do you deliver this valve from? Most of our patients are done from a femoral approach, which is the artery in your leg. This artery is in the groin, and you thread your catheter in from here, go all the way up to the heart. The aorta makes a 180-degree turn here into the heart, and you bring your catheter up and around here and into the heart, and this is where you deliver the valve, okay? In some patients who have blocked arteries down here, that's not possible to do because the arteries are not large enough. And what we've done is there's different ways to approach this, because all roads lead to Rome. You can go directly into the aorta, so you make a small incision in the chest itself and go directly into the aorta. What we found was that approach was almost as bad as doing open heart surgery for these patients, because you were cutting through bone. and their healing process was just as difficult. So we don't do a whole lot of that anymore. There was a way to go through the arteries that are underneath your collarbone, the subclavian artery. But our alternative access of choice is now the carotid artery, right, from the neck. And there's a couple of reasons for that. One is the carotid artery runs just underneath the skin, so it's easily accessible. You can make a 1-inch incision, expose the carotid artery, put our catheters in from there, and it comes. Now you're delivering the valve instead of coming from below and up and around, you're coming from above straight down into the heart. It's actually a much shorter route, and it's easy to do. And this has become our alternative access route of choice in patients who we don't go in from the groin on. Okay, we're actually one of the centers of excellence in this approach. We run teaching programs. Surgeons go to other hospitals to teach how other crews, other surgeons, how to do this. And then when we run training courses here, there are surgeons who come from other hospitals to watch us do these procedures. So there are evolving technologies. There are in Europe, we have 8 valves that are currently available for TAVR. In the United States, there's only 3. I'm actually very glad that we don't have 8. Out of the 8, I can tell you that even in Europe, most people believe that this valve, the Edwards valve, is the best valve. These 2 valves, the Medtronic valve and the Edwards valve, were released about the same time in the United States. They had equal market share when the valves were released. Edwards now has well over 70 to 72% of the market. A lot of people that started with the Medtronic valve have shifted over to Edwards. And that was a conscious decision on our part. We could have picked either valve to start the program with. I'd been doing this long enough to where I could see how one device would function versus the other. And to me, the Edwards valves seem to be the one that I wanted to work with. And it's really been a good choice for us. So this is what the valve looks like. It's a stainless steel cage, wire mesh. There are 3 flappers that are sewn in on the inside, made from the lining of a cow's heart. There is almost a cloth-like skirt at the bottom that helps seal the valve into place so that there's no leak around the valve when it goes in. And this is what the valve looks like under X-ray in the aorta. Okay. That's about the size of the valves. If I was holding it in my hand, that's about what you would be seeing. This is our delivery system. This catheter that you're seeing up here is about the size of my index finger. Okay. So when we do angiograms and we put in stents in patients, the catheters we're using are about the size of a coffee straw. This is about the size of my index finger. It's a large catheter. And that's why when patients are having TAVRs, when they're having a valve replacement, they undergo CT scans that allow us to size the arteries from the leg all the way up to the heart and make sure there's no plaque, no blockage in those areas. And we actually size those down to 1/10 of a millimeter because we need to make sure that our arteries are large enough to accommodate the equipment that has to go in. Because if it isn't, then we have to think about alternative ways to approach the problem. This is the delivery system on which the valve is loaded. It has a balloon inside it. When the balloon is collapsed, this is what it looks like. This is the valve in its crimped appearance. So we take this valve and we actually crimp it with a crimper in the operating room, and it becomes about that size, right? And when it's like in this configuration is how it's advanced all the way into the patient's valve. And then once we're in the right position, we expand it and it opens like this, and the valve locks into place, right? Here's an animation. So here's the device that's going up, and you can see here's our valve. The balloon is actually out in front of the valve, and once we have it inside the body, we bring the balloon back into the valve, and that's to give us the smallest profile that we can, right? Now, once the balloon is in and it's locked in place, we advance over a wire all the way up around the arch and into the heart. Now, here's your bad valve. You can see it's hardened, it's calcified, it's really not opening like it should. We'll bring this around the arch. We'll bring it inside the bad valve. We position it exactly where we want to. We bring the supporting catheter back a little. We can adjust the angulation of the valve depending on where exactly we want to put it. We'll center it properly. Position it within a millimeter of where we need to land it. And then we expand it. So what you're seeing, if you pay attention, is the heart was beating, but when this valve went up, you saw the heart's quivering, okay? So I have to land this valve within a millimeter where it needs to go. That's my margin of error, right? You cannot land a valve in a heart that's beating 60 or 80 times a minute and moving with that kind of accuracy. So what we do is we put a temporary pacemaker in the heart and we speed the heart rate up to 180 to 200 beats a minute. When we do that, the heart, instead of moving like this, is laying there and it's quivering. So it's basically in standstill. And I can keep the heart in standstill for 30 to 60 seconds without any adverse effect to the patient. But in those 30 seconds, I need to land my valve where it needs to go and expand it. So if you walked into the operating room and you see us do one of these valves, there's a certain cadence to what we do, right? And I call out the instructions. There's pin drop silence in the operating room. And it's pacer on, and the nurse turns the pacemaker on. The heart starts going at 200 beats a minute. It's quivering. It's laying there. I'll say inject contrast. That's our dye to position my valve. And I'll say balloon up. We count 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. We give 5 seconds for full expansion of the valve. Balloon down, pacer off, and the valve's in, right? So the actual delivery of the valve is about 10 seconds. It takes us about a half hour to get our equipment in, about a half hour, 45 minutes to get our equipment out. But all the excitement happens in about 10 seconds, right? So here's the actual valve. Here's the aorta. So you'll see now, that's the valve being expanded. So that's what it looks like in the operating room. That's exactly what we're doing. So you pay attention, see how the heart's quivering right now? It's not squeezing. The valve's expanded. Valve balloon down. Balloon is going down. Balloon comes out, pacemaker off, and now we're beating normally. This is the pacemaker right here, this wire here. I want you to pay close attention to this. I'm going to pick a few volunteers to come help me tomorrow. So that's what our valve looks like when you look at it with an echo afterwards. You can see the leaflets are nice and thin, they're moving well. And the calcium in the bad valve is all pushed to the edges, right? And this is what it looks like in the other view on echo. That's my entry point. And so the artery, depending on one patient to the next, the artery may be just underneath the surface, a few millimeters below the surface. The artery might be as much as 5, 6 centimeters below the surface. So what we do is we access the artery with a needle. We put a wire into the artery. Once the wire is in place, we actually deliver sutures inside the artery. And so this little device here allows me to put a suture on the inside of the artery, 2 loops that go inside out, and then I can pull the sutures out through the skin through my entry point, right? And these sit on the side, and then I put my catheter in that's going to help me deliver the valve. And when this catheter comes out, all I do is pull my sutures up and cinch them, and the artery is sutured closed. And that's what the incision and the scar looks like after we've delivered a valve. It's about the size of my fingernail. So this was the clinical trial that showed in patients that were inoperable that you had a better outcome versus standard therapy, which was surgical. The mortality out at 2 years was 43% in these patients versus 68%. And we knew that was the case, but the clinical data actually supported it. This was the outcomes for high-risk patients. The mortality at 1 year and 2 years was exactly the same. So we had a therapy that was minimally invasive that compared with a huge surgical operation. And what we found with the initial clinical trials was that it substantially reduced the mortality, and that 4 out of 5 patients who had TAVR had minimal heart failure symptoms afterwards, right? So a lot of their symptoms resolved. And the procedural complications of valve replacement were few and far between. So this was a really good option, and we had the clinical data to prove it. Similarly, for data, the data for intermediate risk patients was very similar to TAVR. It was actually better in terms of the outcomes. You had a 20% risk reduction in all-cause mortality and disabling stroke as compared to surgical approach. And that sort of starts to come across in all subgroups now. So here's the low-risk trial. Again, the same thing, better outcomes. Non-inferiority trial, but you got follow-up out to 12 months. And these follow-ups have now gone to 4 years and 5 years, and the curves continue to diverge. And the patients that have had TAVR continue to do, have had a TAVR continue to do very well. So I'm gonna skip through a lot of this. Complications of valve replacement, obviously important as well. But here's your mortality for a TAVR, right? As the valves have gotten better and better, the techniques have improved, a mortality for a TAVR is now just about at 1%. 99% of patients are going to come out of the surgical operating room and do really well. And that's actually better than open heart surgery, right? Here's TAVR-associated stroke. So when you're expanding these valves, one of the risks that can happen is that a piece of calcium, a plaque that's on the valve, can break off and go to the head. It can cause a stroke. That happens with TAVR. It happens with a surgical approach as well. That risk is somewhere between 1% and 2% across the board. There are certain devices that are being developed to help prevent that. Little filters that allow you to catch the debris. One of the devices that is approved by the FDA got approved, but the data on it was very equivocal. Not convincing that it worked, because just the process of putting that device in sometimes could dislodge plaque from the carotid arteries and cause a stroke itself. So it was not clear cut that the device was helpful, but there's at least another 3 devices that are currently in clinical trials, and I expect we'll see those within the next few years. And that'll be one other way to decrease the risk of a stroke in these patients. And what's happened as a result of all the data that's being generated is that more and more patients are having a transcatheter valve replacement, and less are having a surgical valve replacement, right? But there is still a need and and there are patients who are better served with a surgical valve than they are with a transcatheter valve, and we'll sort of talk a little bit about that as well. So this is what's happening across the board in transcatheter valve replacements. You can see the patients that we're working on have a lower and lower risk of mortality. So they're becoming more and more low risk patients. When we started out, we were working on patients not infrequently whose risks, the average risk in that subgroup was as high as 10%. We were operating on patients that had a 30% risk of dying on the table. And as a operator, that is a heavy burden to bear, I can tell you. You know, you walk into that operating room with a lot of trepidation. But you know that there's a 70% chance that you're going to bring that patient out, and that patient doesn't have any other option. So you bite the bullet and you do what you have to do, right? So, but that's what it took for us to get the program going, right? And obviously, if things didn't go as planned, there were a lot of people who were happy to tell you that you had no business trying to do this kind of a procedure in a small community hospital like Eisenhower, right? So we've sort of borne the brunt of that, and our community is better for it, our staff's better for it, our patients are better for it. But that's what it takes to bring new technology in sometimes. So these are just a bunch of graphics. I'm going to go through them. So here's, you know, your typical low risk patient, someone in their early 70s. Their surgical risk is only about 2%. The intermediate risk patient is probably closer to 80. And then you've got patients that are higher risk that are close to 90. The oldest patient that I've done with this was over 99 years of age. Actually, she was 99. I did her TAVR on her 99th birthday, okay, on her 99th birthday. And I'd had a conversation with her 6 months earlier, and she was like, I'm not sure I want this. You know, if God wants me, I'm ready to go. It's this, it's that. I said, I'm not going to push you to do anything. You should just know that this is an option, and I'm not offering it to you to keep you alive for another 10 years, but you're getting tired, you're fatigued, you're short of breath. Your quality of life, at least, will be better. That much I can guarantee you. So she came back after 6 months and said, let's do this. And serendipitously, the surgical date fell on her birthday. And I didn't know that, but I went to the pre-op area to have her sign the consent form. And I looked at the name and birth date, because that's what's listed there. And I said, it's your birthday today. She goes, yes, and you're giving me a nice birthday present. So she comes back to see me in the office, you know, a month later. And she says, I don't know why I waited so long to do this. She said, I am so good at all those board games. I'm beating everybody at that nursing facility. She was much more energetic. She was much more, you know, she was just a happier person because she was feeling better. And she came in to see me on her 100th birthday for her 1-year follow-up visit. I didn't tell her, but I got the office staff together and I said, when I bring her out to the front to check her out, we're going to sing her happy birthday. So she came up to the desk to get her next appointment. And there was about 60 people that emerged from all the rooms in the office, and we sang her happy birthday. So it was great. So this is our heart valve program. Our mission is to evaluate and appropriately treat patients who have complex cardiac valve disease. It's a multidisciplinary program. We've got cardiologists, we've got interventional cardiologists, we've got our cardiac surgeons. We all work together. We have the general cardiologist in the office. There are patients who end up requiring pacemakers when we're putting valves in. So our electrophysiologists are on call when we do that. We have one person who is on speed dial. About 4% of patients who get a TAVR will end up requiring a pacemaker. And we know who the person is to call, and we call them, and they come in, and the patient comes out of the operating room with a valve and a pacemaker. So that happens about 4% of the time. I think that's a picture of our first case that we did here. This is our heart team. So the process is basically confirm your diagnosis, get an echo. We do a heart cath and angiogram. We do CT scans to look at everything. And then the patient is seen both by a cardiologist, an interventional cardiologist, and the cardiac surgeon. And then we pick a date and time and go. So we've already talked about different approaches here. What have we done at Eisenhower? This slide is about a year old. We've done over 1,200 patients, now close to 1,300. In 2023, we treated 169 patients. And in 2024, we've done 219. We've had a 30% growth in the program in the last year. We are expecting this year to grow more. I suspect we're going to get to 300 cases this year. We had a record week this week. We did 8 patients this week. That's the most we've ever done in 1 week. And it was all on one day, all on Wednesday, right? So when I do one of these procedures, there's 14 people in the room with me. There's me, there's my team, there's a second cardiologist. We always double scrub these cases. There are 2 cardiologists that do TAVRs on every case. So we think 2 minds are better than 1. And then we have our cardiac surgeons. They're there as well with their team, because if things don't go as planned, we go to the open option. And that happens in 1 out of 500 cases. But there's a crowd in the room when we're doing one of these things. And it's a real commitment to do this, to build this program. That commitment comes from all those people that are involved. And you can't ask people to do these cases ad hoc. That becomes very difficult, right? So we block out a day. All those people that are on these teams block out that day, and that day is committed to doing nothing but TAVRs, right? So we try and make that as efficient as possible. 95% of our patients now are being done without general anesthesia. The anesthesia you get is about the same as what you're going to get during a colonoscopy, right? And what we found is that the sicker the patient, the less anesthesia you want to give them. So we've actually had a couple of patients who we've given them 1 milligram of Versed, and I've actually talked to them through the whole procedure, right? So it's not painful, it's not uncomfortable. We anesthetize the groins. They feel some pressure while we're working. It feels a little funny when you speed the heart rate up to 200 beats a minute, but we tell them that that's what's going to happen. We talk them through it. And the 1 or 2 milligrams of Versed we give them, they don't remember a thing afterwards. So it's really nice, right? Our average time is 70 minutes to do one of these procedures. The fastest time we've done one in is 17 minutes, skin to skin. The first case I did here took us 3 hours and 45 minutes, right? So the procedure has evolved. Most of our patients go home the next day. We are actually now recognized as a benchmark program that puts us in the top 7% of programs in North America, right? And the manufacturer of the valve, Edwards, that makes the valves, has picked us as the only site that is a live site for the benchmark program. So what we did with the benchmark program was we said, let's see how we can create efficiencies. We can't be doing 4 and 5 procedures, and each one of them is taking 3 hours to do. So we actually broke down the procedure in every little part, right? Patient comes to the pre-op area. How long does it take them to get from pre-op to the operating room? In the operating room, gurney wheels in. From the gurney to the operating room table, how much time? On the operating room table, how much time to scrub and drape? Once they're scrubbed and draped, how long for the cardiologist to come in? when the cardiologist comes in, how long to put the needle into the artery, how long to put the sheath in the artery, how long to get the valve up to the heart. We broke everything down into almost 25 subsets, and we began to time these things, right? And I said, let's see where we can save time. And we said, look, we're taking too long to do this. See if we can reduce 3 minutes here. Let's see if we can reduce 4 minutes here. And what we found all of a sudden was we were shaving off 20 minutes, 25 minutes, 30 minutes in a case, right? Well, if you're doing 4 cases, you just save 2 hours. You save 2 hours. So instead of getting done at 5 or 6 in the evening, you're getting done at 4. You're getting done at 3. And it started to become really fun, right? Because we were becoming more and more efficient. And it wasn't like, oh my God, it's 6 o'clock and we're still here. It was like, oh, it's 2 o'clock and we've done 4 cases already, you know? And we have never stopped doing that. We continue to do that to date, right? Every month we go back and look at those metrics. It's almost like a 6 Sigma program, right? Which Jack Welch used to use in GE. He used to revise this process over and over again, and you can continue to perfect it. And we began to do that. And what has happened now is we've sort of taken this program to other hospitals around the country. It's called the Benchmark Program. It's sponsored by Edwards. They fly us out there. Dr. Logsdon and I go, not infrequently, to these hospitals. And we look at them and we walk them through this process. It's not rocket science. And when you begin to point out to other facilities, other physicians, other scrub staff, nurses, how we've done things, they go, well, that makes sense. Well, that makes sense. And then what now Edwards has done is they're sponsoring these teams. They're flying them out here. So we've had 5 hospitals already send their teams out, 3 from Texas, 2 from San Diego. And it's the cardiac surgeon, it's the interventional cardiologist that does the TAVR, sometimes 2 of them, sometimes 3 of them. The entire nursing crew that works in the operating room, the scrub staff, they all come, right? And they all hang with whoever is doing the same job here through the whole day, right? And then we have them situated upstairs in the conference room, and I've got audio video hookup so they can actually see what I'm doing at the table, and they can ask questions, because you can't have that many people in the room. There's already 14 people in the room. So you'll have 2 or 3 that are in the room, and the rest of them will be upstairs. And so there's an active dialogue going on. They're asking you questions as you're doing these cases. And it's been really very gratifying. You know, we go through this process with them. We do sort of Zoom calls initially to identify where there's room for improvement for them. And 2 months later, we get thank you notes, we get calls. You know, we're doing 4 cases, we're done by 2 o'clock. Oh my God, this is fabulous. And it's been a very gratifying process to make that happen. So here's the other metrics on the program. Alternative vascular access. I think we've done over 100 transcarotids now. So we're one of the busiest transcarotid centers. We're doing bicuspid aortic valves as well. The other thing that we're doing is we're doing valve in valves. So if a patient has had a prior surgical valve and that surgical valve has now deteriorated, one option is to do a second open surgery, which is now much more difficult, because more often than not, that patient is about 10 years older, or at least, if not 15 years older, because that's how long the surgical valves would last. Now you're talking about operating on someone that's 80 plus when they were, 65 or 70 when they had their first surgery. You're going to go through a sternum that's already been opened once. You got to get through all the scar tissue that's on the inside. And all of that becomes more and more prohibitive and more difficult to manage. And then the recovery is longer, right? So we are now actually able to take our valve and put it inside of a surgical valve, right? Without ever having to remove that surgical valve. The other thing that we are doing is that to get full expansion of the valve sometimes, we actually have to fracture the old valve frame because that's doesn't allow full expansion of the valve we're putting in. So we've got specialized balloons that are made out of Kevlar, right? They don't burst. And we can go to 80 atmospheres in those balloons and they will not burst. 80 atmospheres is probably about 20 times the pressure inside your car tire, right? And we can crack the frame of the surgical valve to allow full expansion of our valves. So these are just things that have evolved over the years. We've sort of figured out how to deal with these problems. Here's an example of a valve-in-valve replacement. So you can see the surgical valve is right here, right? And this is the TAVR valve going in. It's actually almost easier to do this than it is to do a TAVR. And the reason for that is this is very easily seen under X-ray, right? So here's an example. So this is a surgical valve, and you can see all this blue and yellow. The valve is leaking now. It's not functioning like it should be. And here's the frame of the valve. You see this design here, and we're putting our valve inside that valve, and we're expanding it. So I don't even need to inject any dye to visualize this valve, right? Because I can see exactly where the frame is. And I can line up my valve and expand it inside that valve. And it's interesting to see the patients that have been through open heart surgery that have, you know, their reaction to this procedure, right? And they're like, oh my God, this was so much easier than last time. So you can see this is the result on echo. There's no leak on the valve anymore, and the valve is functioning beautifully. And this is the mitral valve. So a surgical valve that's in the mitral position. And so what we do here is that we actually come in from the groin, but in the vein, not the artery. So we come up the right side of the heart, and we come through what's called the interatrial septum. So there's actually a fibrous partition between the upper chambers of the heart. And what we do is we poke a needle through that fibrous partition. We put a wire across it. We expand that area with a balloon, and then we bring our valve across the interatrial septum here, and we deliver it inside the surgical valve in the mitral position. So you can see how. So you bring the valve in and you expand it in place. So this has just been a game changer for, you know, for patients who otherwise would have required a second open procedure. Here's an example. This is an 80-year-old patient, had heart failure. This is a Medtronic Magna valve, and you can see the valve is deteriorated. On transesophageal echo, that's what the valve looked like. You can see it's the opening of the valve is this black area. It's narrowed, looks terrible. And here we've come across the septum, and this is the valve that we're fixing, or we're putting our valve into, and you can see we expand, and now the valve is fixed. So this patient actually had 2 artificial heart valves previously on their first surgery. And these loops here are stainless steel wires that are holding the patient's chest together after their first surgery, right? And so here's your new valve now. You can see the leaflets are opening and closing, and there's no leak. It's working beautifully. The opening, it looks like it should. So that's our team, the heart team. We talked about them briefly. So I'll stop here and take questions.
Please use the microphone. You're first. Thank you. Okay. Okay, can you hear me okay?
Yes.
Okay. You mentioned the leaflets were made, as I understand, from the lining of a cow is,
Lining of a cow's heart, yeah.
okay.
There's
Of
a part of the
cow's
heart called the pericardium, which is the outside lining of the heart. And what they do is they actually take this lining of the heart and they find areas that are symmetrical in thickness. And these are hand cut and hand sewn inside the valve frame itself.
They keep them refrigerated or something, or?
They actually, these leaflets are treated with a certain chemical process, and that keeps them from deteriorating over a period of time. And that's what actually makes them last 10 and 15 years.
Great,
So
thank you.
when they test these valves, when these valves were released, the FDA wanted benchtop data that showed that they would be equivalent to surgical valves. So what they did was with these manufactured valves, they would take 500 of them and they'd put them in chambers with liquid being pumped through them at the pressures that you would have inside your heart at 400 beats a minute or 360 beats a minute, which was 6 times what would normally be your heart rate. And so for every year that that chamber was running, that was the equivalent of 6 years. So they would run these chambers for 3 years on 500 valves. And every month they go around looking to see how the valves are doing and how many of them have deteriorated. And they were doing the same thing with the surgical valves. And they showed that at least on the bench top, these valves are functioning just as well as the surgical valves are.
Thank you.
Yeah.
Hello, Dr. Khanna. I'm fortunate enough to be in visiting on patients on Wednesday, so I saw how busy you were yesterday. Question, throughout the years, we've seen patients that were in their 90s and then in their 80s, and now we're seeing more than in their 70s. Do you think eventually with the improvement of valves, are you going to see younger patients that don't necessarily have to go through the sternum and open heart?
Absolutely. Yeah, I think that's where this is going. There's actually a company that is developing a valve currently that is purely synthetic. And at least the benchtop data would suggest that those leaflets will never deteriorate. So you would end up with one valve for your lifetime potentially, right? But so there's a lot happening in this space. I'm actively involved with a few startup companies. I've actually helped bring 14 companies from benchtop to commercial. And I've got a few of my own patents. So I'm involved with some of this stuff and I really enjoy it. Yeah.
Yes, what's the normal recovery after the procedure?
This procedure?
Okay.
There's no recovery.
That's amazing.
No, honestly, it's the patient will feel sore in their groin where we went in because you're putting in a catheter about that big. There'll be some bruising, not uncommonly, at our access sites. But people get up and walk the next morning. We have them walk around the unit before they go home. If everything goes as planned, in a matter of 3 to 5 days, most patients will feel much better than they've been feeling, and there's not a whole lot of recovery or recuperation with it. Yeah.
What?
Just one follow-up. I know you're supposed to get better blood flow. What if you see what the result is before the procedure than after the procedure?
You're asking what are the improvement in symptoms?
Yeah.
So now all of a sudden you're not short of breath. You can walk a lot more. You can do a lot more physical activity. Patients who have been having chest pain, the chest pain goes away. Patients who are passing out are not passing out anymore. A lot of patients actually notice the difference almost immediately. even before they get up out of bed and they get walking, they just feel like they can get more air into their lungs. A lot of patients struggle to describe what they're feeling before. And when you talk to them, they say, you know what I had? I said, was it air hunger? They go, that's a really good description. It's air hunger, like you can't get enough air, right? So not with every patient, but there are, everybody's a little different. So we hear that a lot.
Once again, thank you, Dr. Khanna, for speaking tonight. We
Sure.
always learn so much from you. My question is about the mitral valve. We see a lot of clips
Yep.
that are used. And I want you to comment on that, but also, are they putting mitral valves in the existing mitral valve or the one that's been implanted prior?
Yeah. So the device that you're talking about, the MitraClip device, is similar to, the approach is similar to what I showed you, where you put a TAVR valve in a surgical mitral valve, right? We come through the septum. And what's happening with a mitral valve more often than not is not that it's stenosed or blocked, but it's leaking. So the leaflets, instead of coming together like this, when it's closed, come together like this. And the blood is leaking backwards into the upper chamber. And that upper chamber is connected to your lungs. The lungs are filling with fluid, right? So patients are going into heart failure when that happens.
Is that called regurgitation?
That's
going
called
backwards?
regurgitation, mitral regurgitation, right? So what we do is we put a clip that actually holds the two leaflets together. So now if you looked at the valve, instead of the valve being open like this, you get two, almost like a figure of 8. So you decrease the regurgitant area of the jet, of the regurgitation. You decrease the amount of regurgitation. The clip doesn't cure regurgitation, okay? Most of the time, however, you can reduce the regurgitation from severe to mild. Sometimes we put 2 and 3 clips in to do that. It is a good option for patients who are suitable for it. Not every patient is suitable for a mitral clip. And those are decisions that we make on our imaging, right? The leaflets have to be large enough to be able to be captured. Where the leaflets are leaking in the opening, can that be addressed with a clip or not? There's just technical issues there. That said, a mitral valve replacement is already on the books. I believe it's going to become available within a year, maybe a year and a half. So you'll be seeing us doing mitral valve replacements. The tricuspid valve, the replacement for the tricuspid valve has already been released, and we're in the process of getting that going and bringing that to the hospital. That process alone to bring that here is about 8 months. We started that about 2 months ago, right? So it's actually much more involved, but it's one of those things that it's a heavy lift when you start it, and it becomes easier as you go. Everything is difficult until it isn't. So
For you. Thank you very much.
sure.
Thank you for your talk tonight. It's been a while since I've done my visiting, so I'm a little bit out of touch with this next question, and that is, you've explained that, what was it, in 23, it was 169?
Yep.
In 2024, I presume it increased.
It went to 219.
How many open heart surgeries have you had now?
No, so
Or is that increasing
I'm not the
too?
one that does the open heart surgery, so I don't count.
I didn't quite catch you.
I said, I'm not the guy that does the open heart.
Oh, you don't
surgeries.
do any? Oh, I thought you might
Yeah.
split your
No,
time. I didn't know.
no.
Okay.
Yeah, that's the cardiac surgeons. That's Dr. Wilson and Dr. Logston.
I'll
They
have
do
to
that
ask Dr.
question.
Wilson.
You have to ask him
Okay.
that question. Yeah. I have an idea, but I don't even want to venture to say what it is because I don't want to say something that's not accurate. So,
Hi.
I,
My question is, I think you had a diagram, but I'm a little confused. For a person that already has an artificial valve, so when you put the new valve in, do you take the new valve and encapsulate the old valve? Or what happens to the original valve that was in there that's artificial?
so the original valve stays exactly where it was. The new valve goes inside that. The functional inside it. So the functional part of the surgical valve is the flappers, the leaflets. And that's what deteriorates over a period of time. That's what
Okay.
goes bad. The frame itself doesn't go bad, right? So what the patient really needs is new leaflets. And so if you can deliver those new leaflets in a thin cobalt chromium steel frame, all you have to do is expand that inside the old valve.
And I mean, the old valve deteriorates after time? I mean, does it? No,
No, that frame is going to stay there forever.
ever?
Yeah. It's the leaflets that have deteriorated. And the surgical valves used to have leaflets either made out of bovine or
Right.
porcine pericardium, right? It was still the same lining of the cow's heart or the lining of the pig's heart that the leaflets were made out of.
Oh, thank you.
Yeah.
Could you talk a little bit about in the mechanics of how that valve is actually held in place?
Sure.
You know, in a very layman's term, we always talk about says, well, the old valve is all got calcified. That's the bad news.
Yeah.
But the good news about that is that some of that kind of holds the new valve in place. But
Exactly.
there's little barbs or something. Then would you talk about really the mechanics of that?
Yeah. The old valve being calcified is actually what facilitates the whole process of delivering this valve there. If you have a valve that is not calcified, you can't hold the steel frame in place. This calcified scarred valve, when you expand a stainless steel mesh on the inside of it, that stainless steel mesh just locks into the calcified valve itself, right? You don't need any hooks or barbs to keep it in place. So when we look at the CAT scans and we look at the echo and we see how calcified a valve is, we can make a pretty good decision that this valve is going to stay exactly where we're putting it. Right? If you don't have enough calcium in a valve, that's not a valve that you're going to treat with this approach. That valve has to be treated with a surgical approach. So in patients who have a leaking valve, a leaking aortic valve, aortic regurgitation, and no stenosis, meaning there's no calcium in it, that valve right now is best treated surgically. That's rare, but it does happen. Now, we have had patients who are not good surgical candidates and have that problem, and we've done this procedure on that patient. But what we're doing now is we're way over expanding the largest valve we have to try and keep it locked into place. And we know there's a possibility that it may not stay there. But we have a way of calculating how big we can expand it and how much can be expanded safely, because there's only so much you can push the tissues before they tear. Right? So the calcium actually helps us a lot in the valve. Right? Yes, it's harder to work to get that area expanded, but it does a couple of things for us. One, it helps lock the valve into place so the valve doesn't move. Two, it actually gives us some level of protection from overexpansion too. So currently we have different size valves, and on our CAT scans, we measure how big the valve needs to be to go in there. So we have a 20 millimeter valve, we have a 23, we have a 26, and a 29. We have 4 different sizes. And each one of them has a range of size that you can expand the valve to, right? What's coming in the next generation of valves is you can actually dial in the exact size of the valve that you have measured on CAT scan. and you can deliver a valve to be exactly that size. Right? So it's just refinement. The technology just keeps getting better and better.
Are there other questions? Oh, sure.
So I'm wondering, for a heart failure patient who has been taking medication to mitigate certain symptoms, when they have this done and supposedly the symptoms get better, can you reduce medications?
Absolutely.
And is that typical? Is that a gradual process or?
So I've had patients whose ejection fractions,
Right.
pumping capability of the heart is in the 10-12% range. We've done this procedure and they're, handfuls of pills twice a day, 3 times
Right.
a day.
Yep.
And 2 years later, they're not on any medication. And the ejection fraction is normal. It's 55 to 60%.
Okay,
Yeah.
thank you.
Yeah.
We'll look forward to that.
Thank you. My question goes back to the mitral valve, which is not calcified and it is leaking. So what holds the new valve in place then?
So we're not doing the mitral valve replacements that are coming. The technology actually involves delivering a frame to put the valve into.
I see. Oh.
So what you're doing is you're actually bringing a catheter through the mitral valve, and underneath the mitral valve, there are these cords that attach the valve to the heart muscle. And there's a way to deliver a spiral, almost like a spring, around those cords so that it sits right underneath the mitral valve like a cone. And then inside that is where you deploy the valve and the valve locks into it. That's one of the designs that's going to get released eventually.
I see. Okay.
So there's a lot of innovation. There's at least 3 different companies that look like they have a very viable product in that mitral space.
Interesting.
And these companies, it takes them 8, 10, 12 years to develop one of these products. And it takes as many as 3 to 5 years before they ever do a patient. But it's a long journey. It's very expensive, but if they're successful, they do very well.
Okay.
Yeah.
Right. Thank you very much.
Yeah.
Maybe one more question. We got one more question.
Thank you. Any other question?
We're good.
Well, we want to thank Dr. Khanna for this incredible evening tonight. Thank you, sir. He's going to stay around a little bit, and maybe you can, if you have a personal question, he's going to be here for a little bit, and we sure appreciate your time. If I could, I want to tell a story about we had a meeting here. I think they had done their 100th particular TAVR, and we had a luncheon in here, and we invited all those patients, and I think 26 or so of them came that had a TAVR. And Dr. Khanna was one of the speakers, and the reaction that he had was amazing, because he says, if I can almost quote you, it was like, I do these one at a time, and I look out at the audience, and I see 25 people that we've helped stay alive. And he got, kind of choked up. Is that pretty accurate?
Yeah, absolutely, yeah.
And that was amazing. So we see the empathy of a doctor to a patient here, and he's an example of that big time. So big time, really is. Yeah. So I have a couple of other comments if I can even find my notes. I don't even know what I did with them. So they're around here somewhere. I don't know what I did. Thank you very much. All right.